watch this clicked up.
I think we can. Yeah.
All right, so we were obviously holding up just so we were at the official time, but we're gonna go ahead and get started. So welcome to our didactic session, Tasers, Tear Gas, LRADs, PepperBalls, oh my. What we hope to get through is talking about injuries from less lethal weapons, and a big part of doing that is also understanding how these weapon systems work, and a little bit of context of how and why we use them. And so with that, we will introduce our crew. So I'm Jeremy Ackerman, I'm from Emory. In addition to being in the ER there, I serve with the Fulton County Police Department on their SWAT team.
Florian Schmitzberger, I'm University of Michigan. I'm the medical director for the Genesee County, Flint City paramedic division of the Sheriff's Department there.
Esther Hwang. I am also from Emory University. I'm one of the assistant faculty members there. I'm an EM and EMS physician, so I actually got my background in EMS and got interested in tactical medicine from there.
Sam Malakhovsky, also University of Michigan, a resident there right now, former paramedic with prior SWAT support roles.
Excellent, and some of you were with us at the interest group meeting this morning. There is now an SAEM, Tactical and Law Enforcement Medicine Interest Group, and we've kind of been, with a few other people, the organizing core of that. So if topics related to this are of interest to you, make sure you're signing up for that group. We will be looking for people to help out in a variety of roles, planning for didactics for next year, and all of that. As is normally the custom, we have disclosures. I think I have most of the disclosures. There are a few companies I work with. None of them are relevant to this. And then Florian has some support from the Sheriff's Department that we're disclosing. So now you all know. So as I said, we kind of are going to be working through a whole bunch of different types of less lethal munitions. But what I'm going to start out telling you about is a little bit of the legal context and how we approach use of these weapons. And that way, as we get into how each system works, you might start having some understanding about how decisions are made and what you might expect. I think all of us are pretty committed that we've got facts we want to get into your heads, but we think probably we'll get more interesting conversations going by answering your questions rather than us telling you horror stories without any direct interest. So we're going to try to plow through some of these slides, and if you have questions, hopefully we'll have some time for some good discussion. So with that, I am going to jump right in with sort of the legal principles that's behind this. And unfortunately, the legal principles are different in every single state. But the general principle in the United States is that officers can use force, and that may even include lethal force, when there is a valid warrant or if there is reasonable articulable suspicion. And these are words that come out of case law and Supreme Court cases. And importantly, we need to be thinking about the Fourth Amendment for search and seizure, which is where most of our use of force case law comes from. We need to think about the Eighth Amendment, cruel and unusual punishment, which is where most people think police use of force falls under, but the case law does not hold that up. And then we have some due process issues as well. All right, and then on top of that, every agency, every jurisdiction, whether that is a city, county, state, has different rules and regulations. So the important case law, perhaps most important, is a case called Graham versus Connor from 1989. The short version of the backstory was there was a gentleman with diabetes who felt like he was having low blood sugar, and he had his friend drive him up to a gas station. He ran in, saw there was a long line, ran out into his car that peeled away. And a police officer saw that and thought, that's what it would look like if somebody were robbing that convenience store. They pulled them over. The gentleman having the hypoglycemia got out, was acting funny, not responding to commands, and the officers used quite a bit of force on him. And that became a case that went to the Supreme Court, which basically found that actually this was an objectively reasonable use of force. That is, with the facts and knowledge that that officer had in the moment, that it was reasonable, say somebody who might have just held up a convenience store poses a potential threat and use of force would be justified. right? When I tell you that this was a guy who had diabetes with hypoglycemia, the officer didn't know that, didn't understand that. That wasn't the facts they had available. And so from that, we have the Fourth Amendment standard and this objective reasonableness for all use of force. And the definition is the reasonableness of a particular use of force is based on the totality of circumstances known by the officer at the time, and it also weighs the actions that the officers take against the rights of the subject, but also things like the conditions, the knowledge and experience of the officer. It is not something that really you can view as a 20/20 hindsight standard. It has to be viewed from the facts as known to the officer in the moment, which unfortunately is not how our current version of YouTube version of analyzing things typically works, but is in fact what the legal standard is. Another important bit of case law is Tennessee versus Garner. And in this one, there was somebody who was robbing a home, was running away from police. He had broken into an unoccupied home, was running away from police, and was shot in the back. And the case doesn't say that officers can't shoot somebody in the back, but what it sort of lays out is that if that person doesn't actually pose a threat to other people or an active threat because of their escape, you have to be more measured in your use of force, all right? And the reason for bringing up these two bits of case law is when you look at using your less lethal, whether it is excessive or not is viewed under the standards set forth primarily in these two bits of case law, and then on a state-by-state basis, there may be some additional case law. All right, so with that, we have some definitions that are important. We have less lethal weapons, and the definition here is a weapon that, when used as intended, is unlikely to cause death or great bodily harm. Obviously, almost any of the weapons we're going to discuss, and in some cases, we'll give you some examples when used inappropriately, used in a way different than intended, it may cause death and very significant injuries. Less lethal force, any use of force other than that which is considered deadly force. So we kind of get that. And the term non-lethal force is generally used exclusively by the military, and even there it's sort of fallen out of favor, saying we have bombs and guns versus other things that probably won't kill people. It's important to think about the tactics that officers are or should be processing before using less lethal weapons. And the concept here is the use of force continuum. It starts with simply having an officer present. You have verbal commands and you gradually get escalations. And even in use of our less lethal weapons, like say a taser system, the officer being there, the officer drawing the taser, the officer turning on the taser, right? Now there's a laser and a light source, perhaps firing it where it crackles the energy. These are steps on that continuum of use of force well before that weapon is fired. And it's also important to remember from the Supreme Court case in Tennessee versus Garner, that case explicitly, the Supreme Court says you do not have to give a verbal warning before deploying any type of force, right? It is only when it is practically possible. And that feeds into the use of force continuum. You don't have to hit the steps stepwise. Depending on the situation, a reasonable officer may choose to immediately escalate. And importantly, using the right tactics to prevent injury to other people becomes important. On tactical teams, we never use less lethal munitions by themselves. All right, if my team is deploying, ideally, when we are facing somebody, we would like to have 2 to 3 officers, one of whom has a less lethal weapon, to give us some options other than the firearm, one person who is on lethal support, and one person whose job is primarily giving commands, and if the subject is complying, going ahead and doing cuffs and other things like that. And that's a fairly uniform approach across the country. Esther, do you want to tell us a little bit about some of the EMS kind of legal?
Absolutely. All right, so, thank you, Dr. Ackerman.
Yep.
All right, so pre-hospital, so we're going to start getting into a little bit more of the clinical practice now, why this is relevant to you all. I know that's a lot of nitty gritty where we talk about a lot of legal aspects right now, but they're important because it helps us paint the picture of what happens before the patient arrives into the hospital. So show of hands right now, how many of you guys know of any protocols that, I see one over there, know of any protocols that allow you to have paramedics, EMTs, any pre-hospital provider in your system to take out tasers or do render any sort of treatment immediately after a less lethal weapon? I don't see a lot. Wow, okay. Okay, well, this is a great talk then. All right, so I think one of the biggest things, especially in pre-hospitals, and talking to the people before, talking to the crews before they come in with the patient, contamination. A lot of these mechanisms will give you a lot of risks for contaminations. We're going to talk about some of them, including tear gas, pepper spray. Secondary contamination is very, very common. One of the things I always encourage our teams to do is always assume the patient might potentially be a contamination risk. If you are contaminated, you could potentially shut down operations inside your emergency department for a while because they can be hard to clean out. They could be really, really difficult to manage, and you don't want everybody tearing up and crying or coughing and hacking away. Treatment jurisdictions, a lot of them, I mentioned taser barb removal, and so I did not see a very robust show of hands that your EMS system are allowed to remove tasers. Is that something that jogs anybody's memory? So how many people have removed a taser barb before? Okay, there we go, excellent. And another couple things actually fall upon ethics as well, because appropriate restraint use. How many times have you had to explain or try to correct one of your officers or some of the EMS crews that you work with on are these appropriate restraints? Show of hands on that. There you go. So a lot of talk can be, a lot of clinical practice, a lot of adjustment, a lot of education can be done. Having communication with your pre-hospital providers, that includes law enforcement, to help us create a safe environment for a lot of our patients that are being transported so that we can give them proper treatment. Refusal of treatment, this is going to be a very murky area. When we talk about capacity, as clinicians, as physicians, we are the ones that have to make capacity assessments for these patients. It's very important that we try to make it as fast as possible and as accurately as possible so that we can have a safe disposition for these patients. This is going to be a very, very difficult assessment, especially when you have medical control. And if you have a paramedic or you have a police officer helping out, being like, "Hey, doc, I need your help because right now I don't know if this patient is safe to get, to refuse care right now. They really don't want to come in, but this is the situation going on. Are they intoxicated? Can they make decisions?" It's not just, "Hey, what's your name? What year is it? Can you tell me how many quarters are in a dollar?" It might be a lot more complex than that. So a lot of these really the onus falls upon you guys as physicians. So these are kind of like things to kind of plant seeds in your head to kind of talk about, have conversations. Maybe you can work on making protocol updates, maybe working on like clinical care guidelines, especially within your department. Those are things like I really encourage. So we're going to have Florian come and talk about tasers now.
Yeah, we'll get into the different types of less lethal weapons, and I think the prior talks were just so important to emphasize the less lethal and not non-lethal aspect of this, because I think we've all seen some complications, and most everybody here has removed taser barbs. However, there's some other things to really be concerned about with them as well. All right, energy discharge weapons, most in the literature is usually called conducted energy electrical weapon. Whatever you want to call them, essentially they've been popularized by the name Taser, by the company. Doesn't sound very impressive, right? Like 3 amps, strong static shock, electrical current of 30 amps. If everybody here has seen videos of people getting tased, it is certainly impressive. And as ER docs, kind of the first thing that comes to mind is what could be going on with those patients from a medical perspective? What do we need to worry about? The intended use, very briefly, is really to gain temporary control of a situation. and really minimize the risk for everybody involved, be that in the hospital, patient acting violently, or in the field with police. And the proportionality of the response here is absolutely important. And de-escalation is something that is the most important thing with all of this. So really, you've already talked about the different steps of before you move to this, because it's really not not entirely safe thing, and we'll talk about why. All right, how does it actually work? How does a taser work? Essentially, you'll see in this image, very, very straightforward, right? It has what's very nicely referred to as these little blast doors. And really what happens is you get these two prongs that actually make contact with the patient's skin, and a high voltage, low amp pulses are initiated. And the pulses really are what causes the temporary paralysis, this like neuromuscular incapacitation. And it's very brief, and it's not supposed to have long-term effects. However, there's some issues that we need to talk about. So there's some injury patterns, and it makes a lot of sense that only certain body parts should be aimed at. However, with any kind of weapon, there's some risks involved here. So this is directly from the manufacturer as well. Like these are the areas of the body that you should be theoretically aiming for to avoid major injury. But it makes a lot of sense. This is where issues can actually happen. They state very nicely that person without significant comorbidities. We don't know this. We have undifferentiated patients sometimes, and that certainly adds a certain risk pattern. Giving electric shocks to somebody with unknown comorbidities certainly can cause some issues. So the treatment for the expected outcome, in an ideal scenario, you have a single discharge, very brief. You briefly assess them for other trauma, make sure that they didn't fall, hit the head. You assess their cardiac rhythm, didn't change it, normal EKG. You assess for the injury from the taser prongs, no injuries, ideally EMS already removed them. And we won't talk about the removal since most people here have done it before, and it's really just like a fishhook and a non-issue at this point anymore. Now here's the tricky part. It doesn't always go perfectly. And there's actually a fair amount of controversy about this because there haven't been many, but there have been some cases of secondary injury from a taser device. The thing that comes to mind immediately is what happens with the cardiac rhythm, right? There have been a bunch of studies on this, essentially assessing, we know that many patients have gotten injured being tased while running, being tased while near a body of water and falling in and having a near drowning or even drowning event. Combustive materials are certainly a risk as well. But the scary thing to most people here is the cardiac arrhythmias that it may cause. There's been a little bit of investigation also. It is very few companies actually make these devices, and they've been sponsoring some studies. So you certainly have to consider, has there been any influence on this? They have an interest, and few other people are willing to actually sponsor these studies. So there's been some reported potential bias in terms of the outcomes from these studies. I think one of the biggest topics, the biggest articles on this was in Circulation, where basically 8 cases of this X26 taser device were published saying that it can cause electrical arrhythmias, dysrhythmias. And they gave some pretty shocking examples. And really it's really not a very happy heart rhythms here, right? Like if you showed these to any med student, they'd be probably very, they come up with the right answer pretty fast what you need to do next. And the takeaway really is, what we really know is that in animal studies, it has been shown that it can cause cardiac arrhythmias. So really, we know it has a certain risk involved. There's been some rebuttals to this article where they said, well, you really picked like EKGs from that patient's subsequent hospitalization. This may not have been the representative initial pattern. So there's still some amount of doubt how serious these cases really were related to the actual device use. However, it's enough for most people to say, well, we should really be cautious and be careful about them. The studies that have happened have not shown significant rhythm changes, and epidemiologic studies have not really shown a strong link. It's not a huge effect if there is one, but it certainly, case examples show that there may be a risk. Trauma from falls, certainly an issue. Few cases that have been published basically, bring down the old emergency medicine saying of, don't have distracting injuries distract you. Why are they still altered, with their minimal ethanol and they're combative now might be a different reason, hypoglycemia, trauma, something like that. There's certainly possibility from trauma from the actual taser prongs, the barbs. Ocular trauma is sometimes a concern. Bone penetration has been rarely shown in the case literature. Genital injury, obviously terrible, but happens once in a while, but not very frequently. We're talking people are able to publish on these if it happens. So, Rhabdo has been a case that's been studied. It was not clinically significant. I don't think there's enough indication out there to get labs on all those patients that have had a taser application. Thermal injury is a possibility if any combustible material was on there. Pain certainly can be a longer lasting effect, and I also always would like to say the psychiatric risks and psychological risks from this are non-negligible, right? Being in that very violent situation. And sometimes it gets deployed against people who are not violent, but they have a medical emergency, they have a psychiatric emergency. So keep that in mind as well when you assess these patients and have a more holistic view of the patient other than, well, you got tased, your heart rhythm's fine, discharge done. So we'll have time for questions afterwards.
All right, so next up are going to be chemical agents. To any budding toxicologist or toxicologist in the room, I'm sorry if I butcher any of these names. I may try to just use abbreviations. So, all right, so chemical agents are usually broken down for certain behavior types. So I call them the 7 Ds. So it's distract, disorient, disrupt, disperse, disable, and detect. So they can be used to cloak activity. They could be used to flush out activity. They could be used to kind of like create like a distraction of some kind. They're lacrimators. These are kind of nicknames that you can find for these chemical agents. Irritants, tear gas. You hear tear gas pretty much ubiquitous amongst terminology these days. But there are different types of agents that actually exist. CN, I'm really not going to belabor too much because CN has fallen out of favor and out of practice due to its extremely hazardous side effects for humans. That's actually where the word mace comes from. So mace actually is, like bear spray is typically CN. And like I said, I'm not going to pronounce it. I think it's chloracetophenone, but that's the last one I'm going to do. It's just extremely hazardous, so you don't really see it that much. CS is going to be the one that you'll usually attribute to tear gas. OC is the pepper spray. HC smoke we're going to go through a little briefly, but they're really commonly used as carrier agents, typically for like the CS and OC. So the reason why I have them in color codes is actually we have international colors for them. So CN, like I said, keep it as mace right now, but CS international color code is blue. So if you see these canisters, sometimes like if you, for whatever reason, you come across one of them, you know when to run or how to avoid them. This is typically a mucosal membrane irritant, a skin irritant, respiratory irritant. Those are going to be the most common organ systems that are going to be involved. One fun fact is that bradykinin release can be likely in CS and CN. You can have a very, very significant inflammatory reaction. There are rare instances where patients can develop angioedema, anaphylaxis, some very serious life-threatening conditions because of their exposure to CN or CS gas. That is rare. However, that is something that you have to take into consideration, especially somebody who's persistently having respiratory distress, having like persistent symptoms outside of that 15 to 30 minute expected window that a lot of these exposures will usually lead to. Smoke is typically used as a carrier agent. It can be used by itself. It's usually mainly used as like a distractor, but it can be extremely irritating as well, more commonly in ocular and respiratory irritant systems. So international color code is yellow. What happened to my can? But anyways, there was a can that was supposed to be there with a yellow label. But that's actually something that you could also potentially see and have somebody say, I was exposed to something irritating. It could be either the CS gas, it could be the smoke. So it could be one or the other. One of the things is that smoke can carry CS or OC, so you have to take that in consideration. So OC is the pepper spray, and that's the one that you'll see pretty commonly because that is legal in certain states. So that's actually something to take into consideration because OC, or the capsaicin spray, is varied in concentrations and volume over certain states and its legality and whether or not the person's able to carry it, wherever in certain states. This is an odorless, naturally derived substance, and it is usually in an aerosolized form. You see those little pepper sprays that sometimes people have on their keychains. That is pretty much ubiquitously available all over the nation. So you could potentially have some pretty common exposures from this with or without law enforcement involved. That might be something that you'll encounter in the emergency department as well. So usually the chemical agent deployment or CA deployment would be for either direct application, meaning that they're trying to disperse or break up a crowd, or it's going to be for space deprivation, meaning that they're trying to basically have people avoid the area. There are actually multiple different ways to disseminate this chemical agent, and actually the reason why we bring all this up is because some of these can actually create secondary or alternative or other considerations for different kinds of trauma and injury patterns that you might actually start to see when you're taking care of patients. Pyrotechnic combustion that leads to explosives, heat, other kinds of flashes, loud noises. We're going to be talking a little bit more about some of those as well, but expulsion, liquid projectile, powder projectiles, you're going to have some kind of solid pieces that might potentially fragment or hit somebody, or shrapnel. So those are all different types of mechanisms that you have to take into consideration. So if somebody says, I got tear gas, and you're wondering why in the world they have a penetrating injury, that might actually be one of the reasons. So it could be depending on how it was delivered. So main systemic effects of chemical agents, you're going to have multiple organ systems involved. Ocular impairment, respiratory tract symptoms are going to be the most common. You could potentially have wheezing, respiratory difficulty, respiratory distress, failure, sometimes in more serious cases, ocular impairment, significant tearing. Most of these symptoms should resolve after 30 minutes after exposure. So again, if you start seeing exposure, prolonged exposure times, that's something to take into consideration that the patient might be more sensitive or have some other complication or a underlying illness like a comorbidity that might have been exacerbated because of their exposure. So not every person is a healthy person. Not every one of our patients is assumed to be that able-bodied, healthy individual that we sometimes do research on in these cases. So we have to consider that as well. The ocular respiratory, I know we already went through. Dermal, especially with like OC, it's a it can make it very irritating, very hot. If you guys have ever cut up peppers and you know that really bad experience when you're like, oh man, I can't get this off. Those are some of the symptoms that you might actually have, like the burning. It can actually create dermal burns if you actually have a very sensitive reaction to it. So take that into consideration. You might need to consider having a burn team consulted because the patient's very sensitive to it. GI tract, this can actually create some pretty significant GI tract, GI distress issues. Nausea, vomiting, diarrhea is possible in any of these exposures. So I know I mentioned additional injury patterns earlier about some of the types of mechanisms that are deployed, but skin irritants and burns from these agents, but you also have to consider blunt force and penetrating trauma. You might have people who are running. They might end up having a fall. They might end up getting injured. Again, just as like tasers, consider persistent altered mental status not normal within the realm of dealing with these kinds of chemical agents. If you start seeing that, you have to take into consideration, we need to probably do a little bit more workup or try to figure out why your patient is altered. So I know we went through a lot of this. Irrigation is probably going to be your best friend, because do you want your EMS service or your police to bring in a patient that's completely covered head to toe in tear gas? What would that do to the emergency department? That would actually be a very, very bad day for everybody involved. So decontamination is crucial. One thing I'm going to also repeat, if you are concerned that there is a risk of contamination, always discuss with your emergency team, your emergency preparedness department, that maybe we should open up the decontamination bay and get this patient decon safely, and addressing some of the life threats in conjunction with appropriate PPE before you go and really do the full head-to-toe assessment with secondary assessment. Irrigation. So I'm going to really touch upon this briefly, but irrigation usually is carried out with those two, water and 0.9% normal saline. Mild soap and water especially can be useful for a lot of dermal irritants. Have you heard about milk? I'm sure you guys have heard. I see a lot of nodding. So a lot of people, especially the street medics that you see, a lot of people are carrying milk around, especially in recent protests. Is that safe? So I'm from Georgia. How hot is it right now in Georgia? Now think about having a can of milk out there for hours. That's called bacteria. Now, do you want that inside your eyeballs? Probably not. Okay. So you don't want that, and I'm also assuming Arizona. Arizona is really, really hot right now, and it's going to get hotter. So really, ideally, milk is really not a best agent. I know we always do like the milk, especially when we get the jalapenos in our eyes or something like that, on our hands. But it's really not a good idea to do milk in an ocular mechanism. You can drink it, but I would not have you put it in your eyes. Fluorescein exams will actually really be important, especially because a lot of these irritants can actually create corneal abrasions and corneal ulcerations. So that's actually something to actually create and consider as part of your routine evaluation for these patients that are exposed with chemical agents. So I'm going to leave off with basically morbidity and mortality and chemical agent use. Take this into consideration. The health impacts of chemical irritants, this was actually a recent study, and they actually looked into like over 9,000 injuries that were reported, and 98.7% of the individuals actually had full resolution of the injuries. However, 67 patients had permanent disabilities and 2 fatalities were recorded. And this was identified in 11 countries. So this is actually like global use of chemical agents. While most, you could say the majority is safe, there's a safety profile that's actually fairly decent. However, there is the consideration where you have 67 permanent disabilities. Now, breaking those down, there are some that are secondary, like from trauma, from a fall, or a couple of them had like stampede history. So there are some kind of consideration that should this be used, or how is it used, or in our realm as physicians, when we start looking at patients or considering treatment, how do we help render treatment that's going to be the most appropriate for these patients and give them the best possible care? So that's just something I'm going to leave off with about chemical agents. And we are next on to acoustic weapons.
As I pick up the acoustic weapon here, I was going to add on with the chemical agents that there are things that often don't make it into the literature that we see about chemical agents. So Esther mentioned smoke, and most people think smoke, that should be pretty benign. Actually, for us as a tactical team, in many of the situations in close quarters, smoke is deadly force. The mechanisms to make the smoke and disperse it actually will evacuate the oxygen, and so people will suffocate in confined spaces. And so it's one of those things that on the technical side, sometimes we have to know some of these mechanisms really well, and sometimes people say, well, why didn't you do? And no, there's a way that it becomes much, much worse. And there's a lot of nuance with some of these deployment things. I hope we have some time for questions at the end. So acoustic weapons are, in some ways, relatively new in this arena. And as a general kind of principle, acoustic weapons are going to be using sound energy in some form that is pressure waves. to inflict pain, impair communication, and distract. And there are a lot of other things that tactically we sometimes say, but most of them fall into those categories. All right. And in this realm, probably the most common, I'm going to focus most on this, is the flashbang grenades, which technically are not grenades, but more appropriately are called flash sound diversionary devices that generate a very brief, loud, high-pressure wave, usually through use of a chemical explosive. There's a newer technology, newer over the last 10 years, which are properly called acoustic hailing devices. They were actually developed for the military for long-range signaling and generate very tightly focused acoustic beams, potentially at very high energy levels. And then we've had something that the military and civilian law enforcement really have wanted to have work, but has been largely unsuccessful, high-frequency devices that use specific frequency ranges to try to deter people and are largely viewed as annoying. So I'll start with that one first. You can buy one of these, and some stores and shops will set them up. This particular device is set into a frequency range that people over about 19 years old can't hear. And literally they advertise it, put this up, turn it on, and all the teenagers will go away. All right, and again, and they claim it's completely safe and all of that, but literally you can buy this, and it's one of those things, as we lose the higher ranges of hearing, you can't hear it, but it is loud enough that somebody who can hear it is going to be like, that doesn't feel good, and presumably will go away. All right, we got to have some humor in all this. So let's talk about the flashbangs. These are devices that the impulse lasts about 54 milliseconds. Almost all of them are designed also to release a very high level of brightness as well, to blind people as well, usually about 5 million candela. At 5 feet away, it's 180 decibels, which is the important number because for a brief exposure, that is supposedly the threshold for permanent hearing damage. And that also gives you some ideas about how appropriate deployment. You're not supposed to throw it at somebody. It's supposed to land at least 5 feet away. And during that 54 milliseconds, they burn at a temperature of about 3,200 degrees. So these are devices that we have to be very careful about flammability issues and throwing them directly at people. And so out of all that, we get a temporary blindness. Not only is it loud and that's distracting and painful, but part of how our acoustic system works is with loud noises, we're reset our threshold for being able to hear things. And so our hearing resets to that much louder, and that means people are deafened, at least for a few seconds. It is a strong enough pressure wave that it impacts your inner ear, and it is disorienting. It's hard to remember which direction is what. And certainly it is extremely intimidating. On one op where we used it, we put one not thrown near somebody outside, and we heard the person inside the house literally yelling, "I'm coming out, stop throwing bombs at me." And again, it's one, as a less lethal device, that's what we want. We don't want to have to escalate force. And that intimidation, at least with my agency, is a big part of what we are going for. So these are devices that originally were developed as training aids for the military. So a lot of how they work is very similar to military grenades. There's a pin that you pull. There is a fuse that's fuse spelled with a Z. That is a delay from when you pull that pin and release the handle. There's a delay of 1.5 seconds before it detonates. We are trained that when we use it, you remove the pin, you hold it a specific way so you don't unintentionally let go. Before you throw it, you need to see where it is going to land to make sure there is nothing flammable, all those sorts of things there, and also avoid loose objects nearby. That pressure wave at point blank will send small rocks and little things off on a nice ballistic pattern. When we release the device, that lever pops loose, which initiates the fuse. And generally that gives us enough time when we're deploying them to step behind cover so we are not taking the full impact of that pressure wave. In terms of injuries, if you are right near where this goes off, burns are certainly possible. These are primarily with direct contact or very near contact. As you get as little as about 2 feet away, you may see things like mild sunburns as a result, and after that, the likelihood of burns dramatically drops off, except for the issue of secondary fires. Shrapnel in older versions was a major issue. Many of the newer devices use some internal baffling systems to prevent having jets of hot gases coming out quite as forcefully. And some of the older devices, depending on how they would land, the device itself would land blocking enough of the holes, it would turn into a rocket and launch the device at high velocity. And newer devices largely don't have that problem. In confined spaces, the pressures that people will sustain from overpressure, the pressure wave hitting walls, bouncing off, and multiple pressure waves, you can get significant overpressure injuries. So things like eardrum rupture would be the most common, but in a very small confined space, you could even get things like lung injuries. The hailing devices or long-range acoustic devices are something that civilian law enforcement is getting in larger and larger numbers and is being used. So that's a picture of a handheld version that's being used. Among the reasons that these are getting popular is they actually are very useful in situations where they're needed for communication. At some level, they are just very powerful speakers. And that means that you can yell at a large and very loud crowd and actually get where people should be able to hear you despite all of the noise. They generally operate with sort of a communication mode and a threat deterrent mode, where it's a loud, high-pitched warble that's designed both to interrupt your ability to communicate, but also disrupts the inner ear a little bit, so people will start feeling disoriented and a little bit ill, in addition to having the pain of a very loud noise. This is where some of those Supreme Court cases get interesting. There's one court case about using these, which from that, at least in New York, you can use this for verbal commands without giving prior warning. But the threat deterrent, they said that's a use of force. However, in the verbal command mode, it can generate incredible levels of decibels and potentially causes injury. And it turns out the Wikipedia page on these has listed most of the times that civilian law enforcement in the US has used these. And it's something often it's very, very visible when it's done. But for the most part, with the exception of a few cases, there have been relatively few reports of injuries in large crowds. The energy delivery is distance dependent, so with the devices that I've been trained on, there are minimal safe distances, there are volume settings depending on the situation that you are not supposed to use it closer. Closer than certain ranges, you're going to be well above that 180 decibels and certainly will be doing a lot more potential hearing damage. Again, it's primarily ear injuries, although there have been other types of injuries that have been reported. Do you want this one or the?
Do this one. Cool. All right, so our last primary section is going to be our impact projectiles, so blunt impact projectiles. Now, a lot of this is much more self-explanatory than the rest of the things we've talked about. Blunt things cause blunt trauma, and the biggest thing I want you guys to take out of this is a couple of the important caveats to think about when you're in the ER and treating this. So first thing to know about this is, a blunt impact projectile is designed to basically cause pain compliance. Now, they're made out of a lot of things, which becomes really important when we start talking about imaging, which is what we love. So big thing to know is that rubber bullets are rarely rubber. It is usually a composite with usually some kind of heavier core, oftentimes metal, to allow it to travel. And they can be delivered by a whole bunch of different devices. Now, we talked about it, really, pain compliance is the goal of this from law enforcement. Big two things that law enforcement has to always know when using it, and you guys need to know when treating someone, particularly when you get an adverse effect, is the minimum range and where it's being aimed. Now, each device generally has a different minimum range. For example, 40 millimeter blunt impact projectiles, like the ones over there, which are the large ones, 15 yards plus is really when it gets safe. Below that, it delivers catastrophic force that can cause penetration. Other things that we're going to talk about, like beanbag rounds from shotguns, is lower range. But usually it's within minimum range is where you see this become from a less lethal weapon to a potentially a lethal weapon. And then there's the appropriate aim points. So the places where people are trained to target is typically extremities. Generally, lower extremities is the #1 place that people are trained to target. Oftentimes, you see law enforcement trying to bounce these off of the ground to also dump that energy. Potentially upper extremities, potentially torsos, depending on the department. Neck up is always off limits because that is where you get into trouble. Now, obviously, these things are not accurate by definition. That is where some of these areas still nonetheless get hit. Now, it is expected to cause pretty serious contusions and potentially breakdown of skin. That is a normal effect of this. That is an anticipated effect. They can be launched through a variety of different devices. The big thing to pull away from this is if it has a bright color, usually green, yellow, orange, it is most likely a less lethal device, even though otherwise it can look like a ballistic weapon, quote unquote. Now, here's the thing to keep in mind about the catastrophic energy. So let's look at the bottom line here. This is the maximum you can have in terms of joules of energy in airsoft, maximum 2.5 joules. That's like what people electively go in full like face shields and stuff and shoot each other with, and it still hurts really bad. Now, we look over at our things in white, which are our lethal weapons, so 22 caliber, 9mm caliber bullet. 160 and 535 joules, whereas you look over at your 40mm blunt impact round, which is a less lethal weapon, that travels at 208 joules, which is more than a 22 caliber bullet. Now, reason that these are still designed to penetrate less is what we call sectional density, basically on how wide this thing is over energy. But you get close enough, you could still get some catastrophic injury because of that massive amount of energy. Now, these things come in all different forms of shapes and sizes. This is an image from the 2000s, and there is many more since that. Here's where we get into the things that kind of we can see potentially as complications. Now, left is a case from India, I believe. The right is, I want to say Qatar. But left is an intraocular injury from a projectile. Now, here's the big thing to pull out here. Generally speaking, if you have a retained foreign body and you X-ray it or CT it, you will most likely be able to find it because most of them do have a metal core of some flavor that allows it to have that mass. Here's the big thing to pull away, though. If you look really, really closely, there's a shadow right here that you can almost not perceive. That's actually the size of that projectile, and that is that composite shell. And that becomes important because it's usually larger than what you see on imaging. And also, if it traveled a lot through the body, it can fragment. And then you have radiolucent, so things you can't see, projectiles that your trauma surgeons now have to go fishing for. The right is a baton round that was retained in soft tissue from, again, being fired too close. The outside of that is some kind of like external splinting device that EMS used. Here on the right, on the left, you have a left lung pulmonary contusion from a thoracic strike. And then on the right, you have a liver laceration, also from a thoracic strike. Incidentally, both of these were used within protocol and within appropriate distances. And this is still potentially a complication that you can see. Now, what does that mean for us other than what we talked about? First of all, where it hits, go scanning for it, as we love to do. But again, remember that the metal core and the composite stuff, two separate things. Next thing, Think about your other organ systems. This here is an example of commotio cordis that was seen in the French Yellow Vest protests. You could see that very big bruise that looks like a nipple but is actually next to the nipple, and that is a person who had paroxysmal VTAC repeatedly in the hospital after this. And then fragmentation, as we talked about.
All right, furry vessels. So this one's going to be really short because this one's pretty self-explanatory. I think a lot of us have treated dog bites both in the tactical environment and also outside the tactical environment as well. I'm just going to really reiterate what Sam had said. This is just an adorable dog, so I'll try to stay on this slide as much as possible. There's only one slide after this. Sectional density is going to be important. So a Belgian Malinois or a German Shepherd dog, which are usually used for operational canines, in terms of like the takedown, have a PSI in their mouth of about 250 PSI, so that's pounds per square inch. Now, sectional density comes into play because a human bite can also go up to 200 PSI, but our teeth are blunt mostly. Now, think about that sectional density of one of those canines with their little jabby, sharp teeth. They're adorable, but they have really jabby, sharp teeth. So now think about that becoming 250 PSI instead. And that can actually cause significant penetration, even as far as breaking bones. Some of them have proven to show to break through metal as well. So that's mainly the same thing. It's where was the dog bite, what was bitten, and how do I help treat that? How do I antibiose it? You always antibiose dog bites because they can be very dirty. And then you also scan whatever is needed because I have a very low threshold to scan, especially if it's like a larger dog. Now, operational canines is a very all-encompassing term. That's just one thing I just want to, kind of put out there for educational purposes. Operational canines also mean they're also those dogs, not the German Shepherds that you see going, like, they're like taking down somebody, but they can also mean drug-sniffing dogs, search and rescue dogs. There are many, many different types of dogs in the operational canine world. So they could potentially be a kind of shepherd or a kind of like pointer dog or a setter. So there are many different breeds of dogs that are involved. Not all of them are trained to bite and take down and do more violent activity, but it's just something to take into consideration when you're looking at like what exactly kind of dog is that. And that's all I really have about dogs, and it's just something to take into consideration. But I think we're going to open up for some questions, and thank you so much for your time.
Thank you for this talk. I'm curious if you could go over some of the ways beyond case reports that we can advocate for patients that suffered injuries from these less lethal forces. For example, are you reporting these to local police departments? And beyond that, are you using patients' names with this and using protected health information, or are you de-identifying this? Because I can imagine a patient would feel uneasy about having their name and birthday and stuff reported to local PD.
I can start really quickly. I think that's actually a really excellent question. That's actually something that has been challenging, especially getting law enforcement engagement for personally, like from my perspective. So as an EMS medical director, I think in terms of what I hope to do is further engaging on the EMS side more, which might be a better avenue to be able to help you engage, like, and advocate for our patients. One thing, and you had mentioned PHI. I do keep patient privacy maintained because I do think that's important. And I know some of you guys might have different experiences.
Yeah, I can briefly talk about that as well. One of the difficulties is if you want to publish or talk about a patient, they need to have a capacity, need to not be in prison and all of that, because otherwise they might be literally not able to make that decision without potential coercion on your part as well to cooperate. So you got to be really careful about that. I do think that addressing the law enforcement agency that's involved is the way to go. And you can do this without having a specific patient that you're talking about. We can say, hey, we've had an event and we would like to talk about what happened here. And you don't need to give details on that. You just need to say, hey, here's broadly what happened. This is I'm not looking for retribution. I am looking to see what the departmental policies are. Keep in mind, like, if it's a sheriff, they're usually elected. They actually care about their constituents, and most police departments will actually be open to discuss that. Not to say that all of them will be, unfortunately, but I think it's very much worth it to discuss it with them because it's a very worthwhile thing you're bringing up there.
Yeah, I'm going to kind of echo the same things. Finding ways to have open lines of communication with law enforcement. These are all uses of force. Being on the side where I may be in a position to use some of these things, there's paperwork. Like deploying these things, you have to write down your version of what happened. Obviously, we live in a world where increasingly everybody's got body cams and things like that. And at least in the agencies I've worked with, use of force needs to have somebody going through and looking at it. Whether that goes as far as you want, that's a whole separate discussion. But the starting the conversation, asking the question, was this use of force appropriate? Which could be not a policy or an agency level issue, but an officer who made a poor decision, versus you have an agency whose policies say that you can use some of these weapons in inappropriate ways, right? Which becomes an important thing for advocacy, is if you find out the policy is when there are 20 people and they're yelling mean things, we can launch batons at them, right? That sounds like something that makes sense to start a political thing as opposed to other sorts of things. The other piece, and part of why we did this, is having some understanding about how these decisions happen. Some of these situations, you heard a few people say, this is the natural, this is what we expect. And as much as it's painful to see people with some of these injuries are actually the device was deployed, used as recommended, and had the injury that's expected. That's up to you then to decide, should I be advocating for not using these ever, or to say, okay, I have a better understanding. This is not the situation to point to and say it motivates a change. And I think any of those outcomes is a good thing to, and making sure law enforcement understands we're trying to work with them and try to nudge them in what's hopefully a good direction. So great question. We have other questions?
Yeah.
I've read some literature that the chemical weapons that you mentioned can have negative effects on pregnancy
Yes.
later on down the line. Are you aware of that literature? Is that
Yeah.
passed muster?
Yeah, so there are actually some papers that actually show that there's a higher, especially in some of the protests that have historically happened, there's a higher rate of miscarriages that, spontaneous miscarriages that occur as an effect after the after effect, and they have been directly linked with certain types of chemical weapons. Now, the one thing I do want to also point out is that if they are global, and some of the global agents are a little bit more strong, I guess is the best way to put it. There are some that are silicone-based, which is longer acting, longer lasting, and a little bit more dangerous. They are starting to kind of come into the United States sphere as well. So that is something to take into consideration. But yes, there is definitely vulnerable populations, elderly, pregnant women. Those are definitely different populations that we do need to take into consideration, that they need to be monitored, clinically speaking, for maybe longer amounts of time or more specialized interventions if necessary.
One more question? Go for it.
Can I make a pitch for the interest group? So I think the questions are really good, and they come from a place where a lot of people who are traditionally interested in tactical and law enforcement medicine don't necessarily come from, but they're valid concerns that we all have nuanced views on. You'd be really impressed how willing a lot of law enforcement agencies are that doctors be heavily involved, both in their operational planning, and they want to get better medically. So if this is an area that you'd be interested in, they're really open to training and they're really open to guidance from physicians at the resident level, the attending level. So no matter what your view of this topic is, if you wanted to make change, I'd really encourage you to reach out to your agency, because a lot of them are really receptive to guidance from docs.
And to finish out the pitch for the interest group, I think that speaks well for most of us who were involved in getting the group started. Although most of us are coming from the perspective of working with law enforcement already, Most of us are interested in engaging with folks who have concerns and trying, rather than, let's defund the police or whatever good political slogans, to actually have adult conversations and go, what could we be doing better? What is something that we really need to push for bigger avenues for improvement? So even if you kind of feel like you're more on the side of the protesters than some of us wearing uniforms and badges, we would like to welcome you in, because I think those voices are an important part of the discussion of how medicine and law enforcement should be interacting.